Hi. So happy New Year 2023 to all. I've been wanting to do this for quite some time to start webinars, which we launched nearly 2 years back during COVID to a more continuous and online educative platform. And for everybody interested in neuroimaging, not just radiologists, maybe even neurologists, neurosurgeons, medical students, the radiological technicians, technologists, radiographers, so on and so forth. So what we want to do here is bring radiology on everyday practice to the people who are involved in neuroimaging in a more understandable format. So I would be also mixing a few Tamil words because I'm native from Tamil Nadu. So originally ஒரு தமிழ் பையன். So I think there is always a space where you have to understand what we are practicing. And as part of this process, I'll be maybe launching a few videos which are covering both the basics as well as advanced. To start off, I mean, this is something that is a recent a pet project of mine to look at the partial strategic concepts for diffusion flare mismatch in stroke patients. So I thought it's a nice way to begin this. So in the diffusion flare mismatch, Abdina, so what do we mean by a diffusion flare mismatch in stroke patients? And I think everything that you read needs to have a clinical value addition to it. So why do we have to even do an MRI in strokes? It's difficult to get an MRI in stroke in most places. But then in India, there are quite a few centers which still practice MRI as the first imaging modality. And that's because MRI is accessible and is available in the emergency. So, and it doesn't really require sedation because it's a very fast sequence that's being used, diffusion. They would do maybe a non-contrast of MR angio and then add it up with a FLAIR and SWA if required. But in selective circumstances, FLAIR has additional importance. Let's say a patient comes in beyond the lysis window, which is currently 4.5 hours. So then, and then has no large visual occlusion. So ஒரு patient வராங்க and the patient has come within the window period for lysis and is not a candidate for thrombectomy. So what we do in such cases, is there a treatment option? We are going to go for antiplatelets anyway. So in these circumstances, maybe getting an urgent MRI with a diffusion and flare might be very useful. Why? Let's see using a couple of cases. So when we look at something called a diffusion flare mismatch, the concept came about because um, diffusion is taken as a gold standard on imaging as an infarct that is ongoing or nearing evolution. So it's not to say that diffusion cannot reverse. It's been known that diffusion can reverse, and we've seen many patients, especially post thrombectomy, undergoing reversal of diffusion lesions. But diffusion stroke lesions happen first within minutes. A flare takes anywhere between 4.5 hours to 6 hours to form. So if we don't know the time of onset, or if we think it's a wake-up stroke, or we still are not sure if this patient has anything salvageable, பேஷண்டோட பிரெயின் ஸ்கேன்ல ஒன்றும் காப்பாத்துற மாதிரி ஏதாவது டிஷ்யூ இருக்கா இல்லையான்னு கன்ஃபார்ம் பண்ணோம் அப்படின்னா this is probably one such sequence that's really helpful. Why? Because diffusion will show you kind of the core or the evolved or the almost evolving in fact. Flare is going to tell you how much of the changes is going to be permanent. If flare is showing well-established signal change, we can probably be more certain that this beyond the lysis window, it's not salvageable. So flareல ஒன்றும் changes மைல்டா இருந்துச்சு அப்படின்னா maybe this patient has got a chance. And we need data and we need evidence to start changing our practice. And that's how always evidence-based medicine works. So do we have data? Yes. Diffusion flare mismatch has been tried in a couple of studies. We got the extent, we have the wake up, the MR witness. These are few of the studies which have looked at diffusion flare mismatch. And so how do they do it? Is basically qualitative. Qualitative அப்படின்னா just eyeballing it. Diffusionல signal change இருக்கா, flareல signal change இருக்கா. If both are there, then there is no mismatch. Diffusionல signal changes are there, and flare, the signal changes are not yet seen or only mildly seen. Maybe then there is a mismatch positive. So what does it indicate? It basically means this patient could still have some potentially salvageable tissue. There is some area that can be saved or recovered by an aggressive treatment modality. And I've already told this is very useful, especially when the patient does not have a vessel occlusion. Already ischemic strokes have now been divided into the LVO strokes and the non-LVO strokes. So those patients who don't have a vessel occlusion, that is a target for endovascular treatment, then a diffusion flare mismatch could be a potential imaging biomarker for extending your lysis. இத்தனை நாள் 4.5 hours வரைக்கும் தான் இந்த இன்ஜெக்ஷன் கொடுக்க முடியும்னு சொன்னது, we can probably extend it for some time. These studies have looked at anywhere between 9 and few studies even 24 hours. So we still don't know, it's not in the guidelines yet, but in selective patients, this might be a viable treatment option. So on the diffusion flare mismatch, let's go a bit more deeper into it. What if there is doubts if this mismatch is actually present or not? Or let's say there are multiple infarcts and one of the infarcts is showing a mismatch. What do we do about this? These are certain circumstances where the current definitions are not very clear. If we have a single stroke and then we say there is mismatch present or absent, it's more dichotomous. It's okay. But in real life scenarios, we might have multiple infarcts or embolic shower vanduchuna, it will be scattered throughout the hemisphere. What if there is a particular area that is showing a clear mismatch? And if we can say that that is the causative lesion, you can have watershed lesions. They're often asymptomatic. You can have a strategic infarct that gets sitting just in the internal capsule. And you know, internal capsule contains all the corticospinal tracts and are responsible for the symptoms. So what if that strategic infarct is actually showing a mismatch? அப்படின்னா நிறைய ஸ்ட்ரோக் லீஷன்ஸ் இருக்கும்போது குறிப்பிட்ட இம்பார்ட்டன்ட் லீஷன்ஸ்ல மிஸ்மேட்ச் ஃபிளேர் சேஞ்ச் இன்னும் வராம இருந்துச்சுன்னா, should that patient still be a lytic candidate? And that's what we like to see by this partial and strategic concept of diffusion flare mismatch. It could be a surrogate, which means a marker for an evolving infarct in the stroke unum complete agala. And maybe then the radiologist could discuss with the neurologist and say, should you still consider thrombolysis even with the delayed window? Because obviously you have to tell the patient that this is still off label. Guidelines and the chances why two people limit thrombolysis to 4.5 hours, they're worried about bleed, hemorrhagic transmission. Or blockade வந்து வர stroke, hemorrhagic மாறும்போது, the outcomes are even poorer. And that is the biggest fear while you're treating these strokes. So we increase the risk of hemorrhagic transformation when the lysis gets delayed. And that should be taken care of by a multidisciplinary discussion between the radiologist and the neurologist. And that should be explained to the patient, saying that, okay, this might be associated with increased risk, but this is our best shot at trying to reverse the deficits that is most acutely affecting the patient at this point. Obviously, if you don't want to do it, we can go ahead with the antiplatelets, then we have the rehab and so on. So we don't have to be ultra aggressive in all patients, talking about selective circumstances. And that's when we should encourage and tell the neurologist that there is a partial mismatch. There are few areas in the infarct that do not show flare changes. And these often could be strategic and be causative. Once we show them these are the areas with mismatch and these are areas with no mismatch, they can figure out, is this strategic or not? அவங்க பார்த்துப்பாங்க, internal capsule இருக்கிறது mismatch இருக்கா, so it's significant. Watershed area இல்லையா, it's maybe not significant for the symptomatology. How do we see it? So there are a couple of methods, and this is one of our publications that came out recently. So the diffusion flare mismatch can be qualitative or quantitative. Majority of the places currently practice qualitative mismatch. அப்படின்னா ஐபால் நம்ம கண்ணில் பார்க்கும்போது diffusion change இருக்கா, அதே இடத்துல flare change வந்துருச்சா. So we have the images on the left, which are the diffusion images. These are resolved diffusion, so they look very good in quality. But real life, if you don't use some of the older missions, they may not give you such clarity and quality of diffusion images. Right side images are the flare, and we can match the areas of infarcts and draw it out manually. And we can clearly see there are two cuts or axial sections, or upper cut or lower cut brainstem blur. And this patient has got a right paramedian pontine infarction. And in one of those slices, we can clearly see that flare changes are there. But in the second slice, we can see the flare changes are not there. So then this is a brainstem infarct, an acute pontine infarction showing a partial mismatch. And that's where we stop. As radiologists, our role kind of stops there. The neurologist then has to figure out in the particular patient, how are the deficits? Are they evolving, stuttering, having a time course? So then, or are they static? ஒரு டைம் பாயிண்ட்லயே சிவியர் வீக்னஸ் வந்துருச்சு, அதுக்கப்புறம் patient improve ஆகல, deteriorate ஆகல, which means this is a non-evolving stroke, may not actually benefit with a lysis just based on a partial mismatch. And again, these are off guidelines and used for selective circumstances under extreme caution and multidisciplinary discussion with involvement of the patient or the attenders. Whereas a second patient, again, this was a patient that came in beyond window, nearly 16 hours, but had a stuttering course. Initially, mild symptoms, then deteriorated further in the morning and underwent imaging in the afternoon. So it was present since yesterday night. And then we can see again multifocal influx. And அந்த மாதிரி இருக்கிற lesions, we can also see that there are few lesions that are already showing flare change, like here. And this is the genu of the internal capsule, as opposed to the changes here that are involving the strategic posterior limb of internal capsule, which does not show so much of flare change. So this is a partial mismatch involving the posterior limb with a more evolved, in fact, with formed flare changes in the genu. Going back to our anatomy, we know posterior limb of internal capsule carries all the important corticospinal tracts. If this patient has deteriorated recently, so he had mild symptoms in the night, then deteriorated in the morning, and he became more weak on the other affected, the contralateral side. So this is a right capsular infarct. So you would expect the patient to have left hemiplegia that is progressive and shows a partial mismatch that is also strategic. So this is again a situation worth discussing. Should you consider lysis? And then if somebody else says, no, I just feel that there is some change here also, they won't be wrong because it's subjective. When we use a qualitative mismatch, so that is the challenge when using qualitative parameters. So how can we make it more objective or quantitative? So then we have a signal intensity ratios. Few of the studies have used this method. So you draw circular ROIs in that area. Sometimes you can have freehand ROIs over the entire involved areas, and you would get some kind of HU values, CT HU values varumari. In the packs, you will get a signal intensity values for that particular pixel or the area selected. And then we can draw contralateral ROI. And in many pack systems, you will also have some midline automatic lines. Then if you draw an ROI here, the contralateral ROI gets drawn automatically by the machine. So then you would get a control value. And if the ratio between both the normal versus the affected side, if it's going to be more than 1.15, so like for example, if the signal changes on the involved side are 115% times the normal contralateral side, which means the ratio is more than 1.15, they often say, like for example, in a so the signal intensity ratio is 1.6. So this is 1.6 times brighter than this, which often indicates it's beyond the window. 1.15 is kind of the cutoff that has been told, and this is 1.6 nearly, as opposed to the posterior limb, which is a ratio that is more or less equal. It's almost same. Signal intensity ratio is coming to 1, which again proves our point that we saw qualitatively that there seems to be a partial mismatch. So in the stroke flare changes irundalum, a portion of the flare change is more complete, a portion of the flare change is still evolving, and the ratio is still less than 1.15, which means there's a chance that this could still be salvageable. And that is the most important concept when we look at a partial strategic diffusion flare mismatch. These are a couple of examples to explain how we could practice in real life and discuss with our neurologist. And this patient had a right IC occlusion, but with intracranial filling, then doesn't have a target to go for EVT. Of course, if there was more hemodynamic involvement, carotid stenosis is it's like a pseudo occlusion or a tight occlusion, they might try opening up the vessel. The first patient did not even have anything on the basilar except for some ICAD change. So these are circumstances when we don't have much to offer to the patients, and maybe an extended thrombolysis may be beneficial. How do we prove this? We need more data, of course. We need level 1 evidence. We need trials working out on it, or at least we can go back on our retrospective data set and see what is the burden of this mismatch. Majority of centers do get an MRI after the acute phase. They can even see what is the mismatch between 24 and more than 24. We can look at our data, and centers who are practicing MR-based treatment could start utilizing FLAIR more. And we have a lot of other utilizations for FLAIR. We've got the hyperintense vessel sign, which is like a collateral surrogate, which can also be used for mismatch analysis. Maybe I'll talk about it in a later talk. As of now, Thanks, and I hope you enjoyed it.